Okay, thanks, Pally. Thanks for the invitation to speak here today. It's very nice to come along and see so many people attending, so hopefully this will be a good session and you'll find it useful. So obviously this is all about the vaccination for prevention of herpes zoster, the new ZOSTAVAX. Well, in fact, it's not entirely new, but I think a lot of people don't have a great deal of experience with it. Has been available for the last couple of years, but people need to know about it because of the new National Immunisation program, which is rolling out very shortly. So it's been a good opportunity for me to actually revise some of this as well, so I'll share that with you today. What I plan to talk about is just a bit of an overview of varicella zoster disease. So I know there's a bit of a mixed audience here, so I'll try and cover from basics through to a little bit more complex as well, but we'll sort of go over some of the virology, the immune response needed for this disease, clinical features and some of the treatment briefly, and then move on to the Zoster vaccine, why it should be used, some of the safety and efficacy data, and then in particular some of the precautions and contraindications, and I'll talk a little bit about vaccination in immunocompromised individuals a bit more generally as well, because I believe this is probably an area that a lot of people don't know a great deal about. So that's the outline I'm planning. So start with the varicella zoster virus. So this is a member of a large group of viruses called the human herpes virus. So it includes other viruses such as herpes simplex, as well as Epstein-Barr virus, CMV. So varicella zoster is part of that family, so it's also known as HHV3. So it's a double-stranded DNA virus, and like all human herpes viruses, after infection it establishes latency, which means it lies dormant in the body and can be reactivated at a later stage. So varicella zoster causes two clinically distinct diseases, as I'm sure you're aware. There's that primary infection, which is known as varicella or commonly as chickenpox, and the herpes zoster, which is the reactivation, also known as shingles. So just starting a little bit on...
Sorry, I just want to make sure that the recording is going on. I do apologise, everyone. I just wanted to make sure that we are recording the session. I'm quite sure we are, but... Yeah, please proceed.
So just to take you through a bit of the life cycle of the varicella zoster virus, just so we understand what's going on, what the immune system needs to do to control this virus. So after that primary infection with VZV, the virus actually moves into peripheral blood mononuclear cells and then circulates around the body and can infect epidermal cells in the skin. It then becomes latent within sensory nerves and actually lives within areas called the dorsal root ganglia of peripheral nerves or cranial root ganglia, and particularly the trigeminal nerve, which supplies sensory sensation to the face. The reactivation of the virus then occurs at a later point, usually in later adulthood, when the body's immunity against the virus has waned, and that can be due to a number of different reasons, which I'll cover later. So you can see this diagram here just shows the life cycle of the virus. So usually it's either through airborne spread, it's the most common spread, but it can be through direct contact with vesical fluid. Inoculation through the airway where it moves into the tonsils, and from there it spreads in the blood around to other parts of the body, primarily to the skin where it causes the rash that we see as chickenpox. From there it moves backwards down the nerves where it moves into these dorsal root ganglia, which is also shown here. There's this sort of lump here where the cell bodies of the nerves are located, and this is where it lays dormant. So that's the latency phase there. At a later point in time, when Zoster develops, if Zoster develops, reactivation occurs and the virus travels back out through the nerve again back to the skin. However, it only affects that one area of distribution of that one particular nerve, so in what's called a dermatome. So after infection, the virus moves into these CD4 T cells, also known as helper T cells, which are an important part of the immune response to viruses. And in terms of controlling the virus, what's called cell-mediated immunity is very important, which means the part of the immune system which is composed of cells that recognise virus within cells plays the major role. And so that's what's required to keep that virus dormant. It's also important for preventing severe disease when the reactivation does occur. Now, while we do produce antibodies against this virus, and we can measure those in the blood after infection, they probably play a lesser role in actually controlling the virus. So it is there, we can measure it, but the cell-mediated immunity is the primary response that is important in this disease. So when people are in that latent phase, there probably is some boosting of that cell-mediated immunity that goes on, which can come from exposure to the virus outside the body. So being around other people who have chickenpox, for example, might expose us again to a bit of that virus and actually provide a bit of boosting to that cellular immunity. Now, one of the concerns when the vaccination for varicella came out was that this might actually reduce people's exposure to natural varicella. However, really observational studies haven't really shown that to be the problem that was feared. There's also probably some boosting from exposure to the virus within us, so there may be what's subclinical disease that doesn't result in herpes zoster, but a bit of that virus comes out again and the immune system recognises it, and that boosts the immune system immune response again. So just keeps reminding the immune system that it's there. And of course, if people do relapse and have a reactivation and experience herpes zoster, then that in itself provides boosting to the immune system. So it's actually very uncommon for people to have zoster and then relapse and have another episode of zoster. It does occur, and that might be for other reasons, but having the zoster itself does seem to provide boosting to the immune system. Just quickly going to go through a little bit about chickenpox, even though that's not the primary focus of today. So the name varicella, I'm always interested in where these words come from, and it's derived from Latin, and it's really a diminutive of variola, which is the term for smallpox. So literally it's the smallpox. I'm not sure where chickenpox came from. That's sort of been debated, whether chicken just meaning small, or whether it looks a bit, your skin looks a little bit like a plucked chicken after you've had this rash. So it could be one of those things, but not sure. It's a highly contagious disease, either, as I said, spread by aerosol or direct contact with the vesical fluid. Incubation's around 2 weeks, but can be a little shorter or a little longer. And people can be infected from up to 48 hours prior to the rash appearing until once the rash have actually crusted over. It's typically seen in childhood, but adults can experience it as well if they haven't experienced the primary infection during their childhood. In childhood, it's generally mild, self-limiting, very few complications occur, whereas in adults who experience the primary disease or in individuals who are immune suppressed or immunocompromised, they are at higher risk of severe disease. And severe disease can involve neurological complications like encephalitis or pneumonitis, where it involves the lungs. Sure, we're all familiar with what the chickenpox rash looks like, but doesn't project all that well. But these little start off as papules and then turn into vesicles and eventually pop and crust over. It's quite typical to have waves of the vesicles form, so you have different stages of the lesions at different times. So the vaccine for varicella has been available in Australia since about 2000 and part of the routine immunisation schedule since 2005 as a single dose, given as often as part of the MMRV vaccine in young children. So there's some evidence to suggest that 2 doses might be more effective than 1, but particularly in old adults or children, but 1 seems to be pretty effective as well, so probably provides 80 to 85% protection from the virus. Those who have been vaccinated but do get varicella, or what's called breakthrough disease, seem to have a milder form anyway. But it is quite effective at preventing severe disease, so only probably a couple of % of people who have been vaccinated would be at risk of having severe disease. Now moving on to herpes zoster, so it's known as shingles, and just the origin of these words. So herpes viruses, that comes from creeping, or sort of known as the rash that sort of creeps along. I think that's the origin of that from Greek. And interestingly, both zoster from Greek and shingles from Latin both refer to a girdle, so like a belt. And we know that in shingles you sort of do get this belt-like lesion. And interesting, there was this type of belt called zoniai, I can't pronounce that was sort of a unilateral belt, so it had metal on one side and leather on the other. So they did recognise that this is a unilateral condition, and that's where the name comes from. As I've mentioned, it's due to reactivation of this virus. The cell-mediated immunity is important, and we know that reduces with age. So there's this concept of what's called immunosenescence, so ageing of the immune system. So it's a phenomenon that we really know a bit more about recently, and we see it if we look for it in different parts of the immune system. But that seems to be very important in predisposing older people to reactivation of zoster. But younger people can also get this if they're immunosuppressed for other reasons, so I'll go into that much more later. It's a pretty common condition, so over a lifetime there might be up to a 20 or 30% risk of people experiencing zoster, and in those who make it past 85 years, up to 50% of people may have experienced it, so it really does have a preference for those older people. So clinically, it's a neurocutaneous disease, so affecting nerves and skin. Usually presents with this prodrome of some pain, tingling sensation, maybe more generalised non-specific symptoms in the 48 to 72 hours before the rash occurs. The rash looks somewhat like the chickenpox rash, but it's really localised just to that one band of skin, or what we call a dermatome. Usually it's only one dermatome and limited to one side. You may be unlucky and have more than one dermatome affected in rare cases. Usually it will just last only 10 to 15 days and be done by itself. But of course there are some complications which can occur, and it's really these which we are trying to prevent by treating. So one of the main ones and most common is this post-herpetic neuralgia, which can occur, and it's this neuropathic pain which persists in quite a long period of time. So in strict definition, it should be really more than 3 months after the skin lesions have healed to define it as post-herpetic neuralgia, but some form of neuropathic pain can occur for shorter periods of time as well. And again, the same sort of risk factors for the disease itself apply to post-herpetic neuralgia, so older people and immunosuppressed. This is just to remind people about what dermatomes are. So these bands of skin showing the thoracic dermatomes and the cervical dermatomes down the arm. There's also ones down the leg as well. And then in the face, this shows the distribution of the trigeminal nerve. So it's what's called V1, V2, V3, so it's the fifth cranial nerve, which is the V, and then the ophthalmic, maxillary and mandibular branches. So it's particularly an area which can be targeted in shingles. This is a typical rash, which, doesn't present particularly well, but you can kind of see this is sort of a apothoracic dermatome here. This band-like structure doesn't cross the midline, wraps around the body. And then in the face, this is the Herpes zoster ophthalmicus, so affecting the ophthalmic division of the trigeminal nerve. Obviously, it looks terrible in this gentleman. It can affect the eye and have complications in the eye as well. So this is one of the more nasty complications that can occur. In terms of treatment, we know that antiviral therapy can be effective, so agents include acyclovir, valacyclovir, famciclovir. What we're trying to do by treating is to reduce both the severity and duration of that neuritis, hopefully decrease some of the shedding of the virus, so to prevent spread to others who may not be immune. And also then to try and prevent this post-herpetic neuralgia, and that's probably one of the primary reasons we use it. It's indicated for people with herpes zoster who have uncomplicated disease, as long as it started within 72 hours of the rash appearing. In people who are known to be immunocompromised, though, it should be started at any duration, so even beyond 72 hours, because there can be benefits still gained. In anyone who has complicated disease, so things like the herpes zoster ophthalmicus or other complications, again, it should be started at any stage, beyond 72 hours even. So those other complications include the herpes zoster ophthalmicus, but also effects within the eye, so retinal necrosis can occur, Ramsay-Hunt syndrome, which affects the facial nerve, and then other more severe forms where encephalitis, meningitis or myelitis affecting the brain or spinal cord. There are other complications that can occur as well, so secondary bacterial infection of the lesions, so obviously that needs to be treated on its merits and with antibiotics. And then the acute pain management is also a big part of treatment, as I'm sure you're aware. Okay, so now just moving on to the vaccine, so ZOSTAVAX. This is a live attenuated vaccine. So it's actually derived from... sorry, there's someone with their microphone still on. If all people can make sure their microphones are turned off, we can hear you. Thank you. So it's derived from the same virus as the varicella vaccine is, so this ochre-derived vaccine strain. The difference is that compared to the varicella vaccine, it's a much higher dose, so approximately 14 times the dose that's used in the varicella vaccine. The reason for that is that that's what's required to provide the boosting in older people whose immune systems have waned or who have this immunosenescence. The lower dose, if you just use the varicella vaccine, won't provide adequate boosting. The ZOSTAVAX is a refrigerator stable formulation. There are freezer stable formulations, but this is refrigerator stable, given by subcutaneous injection. And what we're really aiming to do by giving this vaccine is to boost that VZV specific immunity, the cell-mediated immunity in particular, so that latency of the virus can be maintained, so it remains dormant and prevents this reactivation in shingles occurring. And as I mentioned, this higher dose is needed for the older patients. So the reasons... Sorry, there's still someone we can hear. If you can just make sure your microphones are muted, it's interrupting us here, sorry. So we're trying to prevent herpes zoster. It has been registered in Australia for people over the age of 50 for several years, but only on private prescription, so it has been expensive and probably not a huge uptake necessarily. But this upcoming launch on the National Immunisation Program is for people aged 70 years with a 5-year catch-up program to cover those between the ages of 71 to 79. What's important to note is it's not indicated to treat acute herpes zoster or to treat post-herpetic neuralgia, and it's not to be used as a replacement for the varicella vaccine. So if you didn't have the varicella vaccine available, it's not appropriate to give this to younger patients, even though it's the same virus. So that's just an important thing to note. In terms of varicella zoster serology, we can measure the antibody levels in people's blood to varicella zoster. However, that's not recommended prior to vaccination occurring. We know that such a large percentage of the population have actually been exposed to chickenpox that almost everybody is going to be seropositive, which means they will have antibodies detectable to varicella zoster. And interestingly, despite this, there's still a large percentage of people who go on to actually develop zoster. So the antibody level is actually not reflective of protective immunity, or it's not a good immune correlate of protection. So it's not useful in the sense of trying to determine if you need the vaccine or not. If there are people who happen to be seronegative, so they haven't had chickenpox before, they haven't been exposed and they don't have antibodies, then that's actually not a big deal, it seems, if they do get the zoster virus as adults. They may be at slightly higher risk of having injection site reactions, but they're not really at risk of having other complications, it appears. So it's not suggested that the serological testing is performed to determine if people have been exposed or not. Even if they say they haven't had chickenpox, many people will actually have had it at a young age or had a mild disease or something else. They've been exposed in most cases. The only situation where it might be useful is if you're considering giving the vaccine to people who have an immune compromise, so perhaps someone with asymptomatic HIV, or if they're perhaps going to be significantly immunocompromised in the near future. And so if you find that person does not have antibody to varicella, then you might choose to give them a primary course of varicella vaccine instead, because they might be at some risk of further complications. But in most cases, those patients are going to be under kind of specialist care, and you can liaise with their specialists if needed. After vaccination is given, there's also no role for testing the serology to see if antibodies have been formed, because they're usually positive beforehand anyway. And it's not necessarily a good correlation of whether they're protected or not. So in terms of the safety and effectiveness of the vaccine, there have been several large studies performed in the sort of workup of this vaccine. So I'll give you the details of a couple of these just to demonstrate the efficacy and safety. So one of the biggest ones, really probably the biggest performed, was this shingles prevention study. So it was a double-blind placebo-controlled trial performed with 34,000 people, adults aged over 60 years. The median follow-up time was about 3 years. It was found that the ZOSTAVAX was able to significantly reduce herpes zoster by 50% or so, and the post-herpetic neuralgia by 2/3, so very effective. There was a greater reduction when you looked in the different age groups in the patients aged 60 to 69 years than those who were 70 to 79, although they were both significant. So, 64 versus 40%. They'll both have significant improvement for preventing zoster, but both groups actually had similar reduction in the post-herpetic neuralgia, so there wasn't much difference between those two. Interestingly, in the over 80s, there wasn't any significant reduction in the herpes zoster compared to placebo, although not a huge number of patients were included in that age group. In patients who did receive the vaccine and then did experience zoster, it seemed that their severity was lessened, so the post-herpetic neuralgia was less severe, and they had less of the other complications as well. So there were some additional benefits even if they did get zoster. In terms of safety, really no major safety concerns from those trials were found, and generally tolerated fairly well. This is just a little bit of a graph from the trial just showing the difference between the placebo arm and the zoster vaccine arm. So on the left there showing the rates of post-herpetic neuralgia, so clearly a difference there, and that was statistically significant, and also for rates of herpes zoster itself, so a significant difference. And some of these patients followed out to 5 years. A second trial that was performed specifically looking at the age group of 50 to 59 years. It's called the ZEST trial, and that had a large number of patients as well, 22,000. Slightly shorter follow-up, a mean of only 1.3 years, but again, a definite difference was shown in effectiveness between placebo and the vaccine. So about 2 per 1,000 per year, person years versus 6.5 per 1,000 person years, so quite a difference. So it was about 70% effective at preventing herpes zoster. This study didn't actually look at the effect on post-herpetic neuralgia though. Now, one of the questions we have still lingering about the zoster vaccine is how long does it last for, and will revaccination be required? So far, the really most solid data we have shows that it is effective out to about 4 years, but beyond that we're still a little bit unsure. There is some data, but it's a little bit limited. What that extended data does show is that there is likely to be a decline in the cell-mediated immunity with time. So even though there is still an effect that can be found beyond 4 years, it does seem to wane progressively. It's not yet really known or defined if and when revaccination will be required or if it's safe. I think that's just more, it hasn't yet been really studied well enough rather than there's going to be any particular problems, but we don't know till it's actually looked at in more detail. So at this stage, it's certainly not recommended There are some extension studies as part of that first study I mentioned, the shingles prevention study, looking at groups from the 4 to 7 years group and also out to 7 to 11 years. But they're very few numbers, and as I mentioned, there does seem to be an effect of wearing off with time. So hopefully there'll be some more data that comes along about whether further vaccination is useful, is tolerated and is effective, but not yet being performed. So at this stage, these are the recommendations for the ZOSTAVAX. So under 50 years, not recommended, not likely to be useful because in that age group, the prevalence and incidence of Zoster is quite low, and the incidence of the complications we're trying to prevent are quite low. So you have to treat a lot of people to get any benefit, so not really effective. In patients above 50 years, there does seem to be benefit, but it varies a little bit depending on the age group. So the 50 to 59 years, they probably will gain benefit from the vaccine. However, it's still relatively lower in incidence, so both Zoster and the complications. So how much benefit they gain is sort of a bit less, I suppose, compared to older age groups. And at this stage, because we don't know about revaccination and wearing off, you wonder if giving it too early might mean that the patients, the effect wears off before they actually enter that high risk age. So, maybe it's not necessarily not recommended, but certainly not being covered under the National Immunisation Program yet, because it doesn't seem to be as much benefit going to be gained from that group. The 60 to 69 year age group is sort of coming up into a more important age group. I think still has those questions about whether the wearing off effect might mean that they lose protection by the time they enter the most high risk group. I've highlighted there the 70 to 79 age group because that's the age where the vaccine has got probably the most benefit on a population basis, so likely to really prevent complications and infection over the greatest number of people and have the greatest benefit for individuals. And that's what's covered under the program. Above 80 years, it seems that the effectiveness of the vaccine wears off, and that's probably the immunosenescence. Really, at that age, you don't really generate as much of an immune response. You don't get as much benefit, although some still might be provided. So it can be given in that age group still. In terms of precautions or actually contraindications, obviously if they've had any hypersensitivity to previous vaccinations that share components with the ZOSTAVAX, particularly anaphylaxis, that would be a contraindication. People with primary or secondary immune deficiencies, I'll go into that a bit further, or if they're on immunosuppressive medications, that really needs to be carefully looked at. Active untreated tuberculosis pregnancy is unlikely to be an issue because this is not indicated for people under 50, but you never know, the envelope's being pushed a bit in that area. And another question that's been raised is whether it can be used in people who've had previous herpes zoster. So at this stage, there are some recommendations that say it can be given in those patients, but probably to wait at least a year before giving the ZOSTAVAX. Now, I guess that's maybe still a little bit up for debate, but certainly not completely contraindicated because, as I mentioned, people who've had Zoster are at lower risk of further episodes, but can still occur, so can be considered at least in those people. In terms of other adverse reactions, it's quite common to get injection site reactions. You can also see a localised vesicular rash. It looks a bit like the varicella rash at the site of injection, rarely. But in those people, that actually contains potentially infectious blister fluid, so that needs to be kind of considered if people do get that complication. Obviously, I mentioned about the anaphylaxis. So, of note, the constituents do include traces of gelatin from bovine gelatin and also neomycin. But if people have had used topical neomycin and had contact dermatitis, that's not considered to be a contraindication to the ZOSTAVAX. There have been rare cases of transmission of the vaccine-derived virus to susceptible contacts of patients given ZOSTAVAX. So at least some caution in people who have immunosuppressed people within the household, particularly if they develop those complications like the blistering reactions. Whether antiviral therapy might impair the effectiveness of ZOSTAVAX has been considered. So people might be on antivirals like acyclovir, valacyclovir or famciclovir for other herpes viruses, for example. And potentially that might interfere with the effectiveness of the varicella zoster vaccines. So what the recommendation is it's stopped at least 24 hours prior to vaccination and withheld for a further 14 days after vaccination. Hopefully that won't lead to any other complications, but that needs to be thought of as well. So in terms of co-administration of vaccines alongside the ZOSTAVAX, there's some slightly conflicting information out there. So the ZOSTAVAX product information refers to two vaccines. So the inactivated influenza vaccine says that can be given at the same time as ZOSTAVAX without a problem. However, this states that the pneumococcal or Pneumovax 23 shouldn't be given at the same time as ZOSTAVAX because there's some data to suggest that it leads to reduced immunogenicity or reduced effectiveness of the ZOSTAVAX. Now that's based on some antibody level testing, and so as I mentioned already, that doesn't necessarily correlate with effectiveness of the vaccine. So that's, I guess, slightly dubious in my mind about whether that's a real problem. And in fact, that's been looked at in Australia by the ATAGI group, so a group of experts on immunisation, and is listed in the Australian Immunisation Handbook that, in fact, ZOSTAVAX can be co-administered with any other vaccine, including Pneumovax 23. There have actually been some observational studies where this has been performed, and in fact it doesn't seem to have any impact on the effectiveness of the ZOSTAVAX, so there are not higher rates of zoster occurring in patients who had the Pneumovax given at the same time. So I think that would be my recommendation. That's the sort of Australian recommendations, it seems, as well. Can be given at the same time as other live vaccines if those are required. Otherwise, they should be given separated by at least 4 weeks if you're going to give live vaccines following the ZOSTAVAX. Now, another question I was just asked to address was about inadvertent vaccine administration. So for whatever reason, if the vaccine, the ZOSTAVAX, was given to somebody who shouldn't have received it, such as an immunocompromised individual, that person should be urgently assessed and, if required, specialist consultations sought, because if they're significantly immunosuppressed, then they might be at quite high risk of having complications. But if they've actually just got sort of low-level risk, then it might not be such a big deal, but the assessment should at least be performed. If they're assessed to be at high risk, then antiviral therapy may be required, might have some impact on reducing the potential for complications. So, yeah, accidents happen, mix-ups happen, so just to be aware that shouldn't just be ignored. Another question that was raised was whether if somebody who's received prior vaccination, say with varicella or zoster previously, was then given the ZOSTAVAX again, is this an issue? I guess there's insufficient data to be completely sure, but at this point we don't really know whether there's any particular problem with giving the ZOSTAVAX repeatedly, but at this stage it's not really recommended due to lack of data. There's not really any evidence to suggest it would be a particular problem or that they would have a risk of major complications, other than perhaps having a higher rate of some of the local injection site reactions, perhaps. But it shouldn't be a major problem based on what data is available. Okay, so I'm just going to sort of speak a little bit more broadly about the vaccination of immunocompromised individuals and also then how this relates to ZOSTAVAX. So people who are immunocompromised, you've got this sort of balancing act that needs to be considered. So Not only are these people at higher risk of infections, including some of the vaccine-preventable infections, but they're potentially at higher risk of some complications, particularly to live vaccines. So needs some careful consideration. Broadly, in this group of people, though, some questions to think about are if they've become immunosuppressed during their adult life, are they still protected from their previous vaccinations? You might be able to look at antibody levels, which do correlate to protection for some viruses, but that's not always available, as I've mentioned for Zoster. Will patients be able to respond to the vaccine? So if they're immunosuppressed, is it actually any use giving it to them? If it's at all possible, it's a good strategy to vaccinate these people prior to them becoming immunosuppressed. So if they've got something that's known, that's planned, like upcoming commencement of immunosuppression for a rheumatological condition or something else that maybe isn't very urgent, then giving them vaccination at least 1 month prior would be good, or for elective splenectomy, for example, that would be optimal. If that's not possible, then you need to wait kind of at least 6 months, perhaps longer in some groups, until either the chemotherapy or radiotherapy or whatever other immunosuppression has been completed. I'll talk a little bit more about that. And then the other question is, could this patient be harmed by giving a vaccine? So that's really relevant for live vaccines. So we can kind of think about immunocompromised hosts or individuals falling into a few different groups. So there are those patients who are really severely immunocompromised, and I've listed them there. So this is not necessarily an exhaustive list, but are the types of patients who we'd consider to be quite significantly immunosuppressed. So people who have active malignancies, who are receiving chemotherapy or radiotherapy, who have generalised malignancies, so maybe not skin cancer that's been resected and not known to have any spread, but a generalised solid organ or haematological malignancy. Someone with aplastic anemia, so just really lacking different cell lines of blood cells. People experiencing graft versus host disease after transplantations. HIV infection, now that depends on sort of what stage of disease they're at. So certainly people who are significantly immunosuppressed, who have low CD4 counts under 200, which is sort of the cutoff we have for AIDS-defining illness, or who have a history of AIDS or who have ongoing symptomatic disease, would fall into that sort of more immunosuppressed group. Now, all these patients are going to be under a specialist in some way, so again, you're not going to, in primary care, going to be making this decision alone. People with primary immunodeficiency, now that's kind of a big group of patients, but if you're uncertain, again, consulting others is recommended, but things like antibody deficiencies like CVID, common variable immunodeficiency, who are people who are on immunoglobulin replacement, or kids who have had severe combined immunodeficiency, for example, definitely fall into this group. People with minor immune deficiencies, just like IgA deficiency, wouldn't be considered to be severely immunocompromised, though. People who have had solid organ or hematopoietic stem cell transplantation, who are within 2 years of the transplant, are particularly immunosuppressed. Or people who are beyond 2 years but still on significant immunosuppression. Or others who are receiving immunosuppression for rheumatological disease, gastrointestinal disease, or other autoimmune disease, who are on immunosuppressives or high-dose corticosteroids, would also fall into this group. Then there are people who are sort of moderately immunocompromised and who are a little bit grey, so who have asplenia, functional asplenia, renal failure, chronic liver disease, diabetes, or people with HIV infection who don't have severely low CD4 counts. So, are at some risk but not high risk. Others to sort of think about are those people, which is a growing group, who are receiving biological therapies, so things like TNF inhibitors, infliximab, who've had rituximab or other monoclonal antibodies, which are now commonly used in rheumatoid arthritis and inflammatory bowel disease. So that's kind of an emerging area. Again, if possible, if the vaccines can be given a month prior to commencing immunosuppression, that would be ideal, but that's not always the case. there are sort of varying recommendations, but it may be necessary to wait 6 or 12 months after completing therapy before you think about giving live vaccines in that group. And then there are people who are sort of on low or moderate dose immunosuppression, which I'll talk about a bit further as well. So just to remind everyone which are the commonly used live attenuated vaccines, so MMR, the varicella zoster, BCG, which is not used a great deal in Australia, but people might have received that overseas or if they're travelling, rotavirus, and then in travellers, yellow fever and typhoid. Oral polio is, but it's not currently being used in Australia. We're using the IPV. Intranasal influenza vaccine is available. It's a live vaccine, but generally not in Australia. It might be used overseas. And then sort of a historical note, the smallpox vaccine. Although in this era of bioterrorism, we never know, that might pop up again as something that gets rolled out. So I'll just cover a few of these specific groups in a bit more detail. So starting with HIV infection, I've mentioned for those advanced immunosuppression patients with HIV, live vaccines are definitely contraindicated. If they have a history of AIDS, if they've recovered, they're still at risk, but it might be appropriate in some circumstances. Or if people have ongoing symptomatic HIV, even if they've had immune recovery, they might still be at risk. So liaison with their specialists would be required. In terms of ZOSTAVAX, some of the ZOSTAVAX trials did include patients with HIV, but they were all well controlled, who were considered to have conserved immune function on treatment without other complications. And in this group, they found that the vaccine seemed to be immunogenic. It was able to mount show an immune response, and it didn't lead to any complications particularly. So that's sort of in line with the recommendations. In terms of ATAGI and Australian recommendations, they sort of take a view that it should be really a case-by-case basis and discussion with specialists because these patients can be quite complex. So I think that's not unreasonable. Patients who are receiving corticosteroids, now topical steroids or inhaled steroids are not considered an issue for receiving live vaccines. And also people who are on replacement therapy, so who have adrenal insufficiency and are just on replacement dose, cortisol, for example, that's not considered to be immune suppressing dosing for those patients, so it's not a contraindication to live vaccination. However, people who are on high doses, even for a relatively short amount of time, can be relatively immunosuppressed. So for adults who are receiving 60 milligrams per day of prednisolone or equivalent of another steroid, or children who are receiving 2 milligrams per kilogram per day or more, who have had this dose for a week or more, should be considered to be relatively immunosuppressed. People who have had more than 20 milligrams per day for more than 2 weeks are also considered to be immunosuppressed for this purpose. And you probably need to wait at least a month after the steroids are completely stopped before considering vaccination with live vaccines. People who are on a low-dose vaccine, and in this instance is considered to be less than 20 milligrams per day is relatively low dose, doesn't seem to be a contraindication to using live vaccines. So in the ZOSTAVAX trials, some of these patients have been included who were on 5 to 20 milligrams per day. And again, the testing showed they were able to mount an immune response and appeared safe. So that's the trial evidence. In terms of other immunosuppressants, so the biological immunomodulators, like I mentioned, it would be considered to be a contraindication for live vaccines, including ZOSTAVAX, if they're currently receiving the biologic therapy, and perhaps even up to 12 months. So we know the effect of rituximab, for example, can certainly persist for 12 months after it's been given. If there's any uncertainty at all, though, it's always worth speaking to the person who's prescribing that medication. In terms of other immunomodulators, the non-biologics, which may or may not be given with steroids, as long as the dose is not high, live vaccines and ZOSTAVAX are not considered a contraindication. So For example, methotrexate of less than 0.4 milligrams per kilogram per week, or azathioprine less than 3 milligrams per kilogram per week. Above that is considered to be higher dose, and vaccine shouldn't be given though. Okay, so that's sort of rounding out the talk. Just to summarise, I think what are the main points related to the ZOSTAVAX and herpes zoster itself. So it is a particularly common disease, as was pointed out, but particularly in older people as the immune responses wane. And the complications are actually pretty common as well, particularly in those older patients. So that loss of the cell-mediated immunity is what leads to the loss of control of that latency in varicella zoster and the reactivation. And there's good evidence to show that ZOSTAVAX is able to boost that cell-mediated immunity and therefore reduce the rates of shingles and also the complications like neuralgia. Of course, it is a live attenuated vaccine, so the relative precautions need to be taken, particularly in immunocompromised patients. And that sort of grey area is people who might be on low or moderate immunosuppression, have had previous biological therapies or have some of those kind of moderate range immunosuppression, and so they need to be considered individually. Okay, so that's the end of this part of the talk, and I'll hand over to Paul.
Thanks, that was really informative. We might just hold on to our questions for now. I'd rather just we have the next speaker present and then we can have questions open. So next we've got Dr. Paul Leffler. Paul currently manages the immunization program for WA in his role as the medical coordinator for the prevention and control program here at CDCD, and he's going to just give us an overview of the program. Paul.
Thanks, everyone, and thanks, Jack, for that fantastic overview of the ZOSTAVAX. It was really helpful. As some of you know, I've probably seen you in here before. I've been in Australia for 8 years managing the immunization program, and before that, as you can probably tell from my accent, I was working in the United States. I'm one of Australia's newest citizens in the last couple months, but before I did that, I did my civic duty for Australia and voted in the U.S. election. Anyway, on to the subject at hand. How many people here have had Zoster in their life? Okay, I thought there'd be a few of you because I have. I got it when I was 50, and I tell you, it was really, really quite painful and debilitating. So I'm happy that we have a program that's going to target people that are most at risk of getting the post-herpetic neuralgia complication, which is really the debilitating after effects. Most of us would have recovered. I'm assuming you all did. Recovered after several months. For me, it happened on my vacation in Europe, so it was a bit of a downer, but that tells you how stressful my vacations are with my family. But it's really, we're trying to, in a public health perspective, trying to prevent the post-herpetic neuralgia that can be really disabling, and actually some even myelitis that can occur and result in really impaired gait and other function. So that's what the program's about. It's going to launch officially on the 1st of November across the country. I heard today that the federal minister might be going out in advance, maybe a week before, to announce that it's going to start on November 1st. But we're going to allow you to start ordering the vaccine tomorrow through the regular channels. So we have a 2-week cycle of distributing vaccine to get it to all the providers in WA. So that'll open up tomorrow, so everyone should have an opportunity to get it before the program officially starts. We've really worked hard to try and make sure WA has enough vaccine for our population. My belief is that uptake is going to be pretty high. Raise your hands if you think that there's going to be a lot of patients 70 to 79 that want to come in and get a free vaccine. Yeah, that's sort of my read on it, just knowing my parents, if you were offering a free vaccine, they'd be there. So we have enough to load the pipeline because everyone's going to get some, but we are going to have to, in the early days, try and make sure everyone gets vaccine, so we may not be able to fill massive orders. What we've done is done a survey of our providers, and 40% of you that responded really wanted the entire allotment allotment of the state for the first 2 months. So, and we understand that, but we're going to try and manage the stock so everyone's got some, and we'll need to reassure anxious people that they will ultimately be there for them in the coming months. So if you do experience a shortage early on, you know that we're working hard to try and get you as much vaccine as we possibly can, as fast as it can be shipped in from the overseas supplier. Okay, I don't really have any more to add. No reason to drag this out, but I really wanted to open it up. If you have questions about the program, you can ask me, but if you have questions, clinical questions, to give you a chance to ask our expert that we have here, we're really lucky to have an adult immunologist here to take our questions. So with that, I'll moderate for you if you want to come up. If we have any questions following the presentation.
You had the word diabetes on your modern mind. Is there a cut-off because you're eliminating most of these? What's the population?
Yep, so the question's about whether diabetes, who needs to, which diabetics might be considered to be immunosuppressed. So, yeah, obviously that's a big group of people, and I think really it's going to be those who have poorly controlled diabetes, who have had sort of evidence of recurrent infections already. It was in that moderately severe group, so it wouldn't be in that group where you think it's an absolute contraindication.
Think about comorbidities with the diabetes, because everything goes hand in hand. I can think of some younger customers that have comorbidities are really quite bad.
Yep, so just a comment that there are some patients with diabetes who have comorbidities that are quite bad. A lot of the sort of people with comorbidities were excluded from the trials, so I guess we don't have that sort of direct evidence, but the recommendations are still that chronic illnesses are not a contraindication to giving the vaccine itself. So when you read the sort of the product information and other recommendations, things like hypertension or underlying heart disease or diabetes are not really considered it to be a contraindication for ZOSTAVAX. But if you have someone who's getting recurrent infections and you think you're worried that they might be actually more immunosuppressed than you realise, it might be worth kind of addressing that anyway, and holding off on the vaccine if you've got that sort of concern. Or but no, you certainly don't need to exclude all diabetics.
So would it be safe to say, Jack, when I scanned the literature really quickly, I didn't see horror stories coming from countries that have been using this vaccine in large numbers, like the United States, for some time, based on mishaps that had occurred. Is that your sort of understanding?
Yeah.
So I think there's sort of a practical approach to this, is that you need to be reasonable. If you know somebody's significantly immunosuppressed, you want to get some consultation, but you don't need to be overly fearful that an accident will occur to say you went into a diabetic and it'll be a huge problem. That hasn't been experienced with this vaccine use in other countries where they've been using it for a few years in big numbers.
And so that was sort of a general thing for live vaccines all over. So I think you probably have experience with giving live vaccines to plenty of these types of patients anyway. Potentially.
It would also be fair to say that some of these patients that Jack was describing, actually they are at high risk of getting zoster and post-herpetic neuralgia. So if we can get most of them protected through vaccination, that's a real positive. So
yeah, no, absolutely. So they're the higher risk patients anyway. Exactly.
I can potentially see some very grumpy 80-year-olds.
Aren't they always?
So that was we're going to more. How do we approach the grumpy 80-year-old that had their birthday 3 days ago?
It is going to be an issue. It's something I neglected to say. The program that we're rolling out is really officially it's a program for 70-year-olds, but there's a catch-up for people up to 79 that's going to go on for 5 years. So really, I mean, you can think that as launching, we're going to cover 70, 79. I think you'll find some even grumpy 69-year-olds who that want to get it for free. And essentially, the vaccine is available, but the publicly funded program is really targeting the folks where we think the vaccine works the best to prevent the most serious complication. And that's where the public program is. I haven't checked yet, but we probably should. Our new private insurers cover this in any way. What's that?
That's a faster.
Okay, so we'll do a ring around and try to determine what support is, because of course, if I just use my parents as an example. Money mattered when they got older, and they'd be
concerned just about having to pay for it. But it is a difficult space. We only have publicly funded vaccine for 70 to 79, but it is available if they really want it through the private market.
Can I ask a question? DVA at one stage were actually funding ZOSTAVAX for their Bourke patients. Is that still available or is that stopped?
I don't know, actually.
As far as I know, it's definitely, and it's just a case of directly contacting DVA and going from there. They will do it on recovery.
Okay. I mean, actually, that's something I would take back to the Commonwealth because I think we should sort this out about what insurance is being covering it and what national programs might be covering it through another avenue. So
it's something the DVA really shouldn't be paying for.
Well, the other thing I should bring up is that as of a couple of weeks ago, we launched a new national immunization register. It's called AIR. They took the C out. It's the Australian Immunization Register, so it will accept vaccinations for any age group. And so the goal would be that these get recorded. If you put in your practice management software, it should move over to AIR the way ACE data is supposed to, right? But the goal would be that ultimately we know if somebody's had it before in their life. And so when those tough questions come up about revaccination, we'll know where people stand because I'm having to look through paper records. Other questions?
I was going to ask you a couple of questions about the programme. Firstly, I'm sorry I came late, so I don't know if this has been covered already, but in practical terms, what feedback, if any, do you require in terms of notifying you who or hasn't had the vaccine?
In practical terms, we just needed to go to the Australian Immunization Register. I would say, on the other hand, it's not because I'm particularly worried about notifying us about other things. If you do have a patient that has an adverse event, we want you to tell us about that through our existing system, right? My view is that we need robust adverse event surveillance, mainly because they show vaccines are safe when spurious associations arise. But especially when you roll out a new vaccine, it's important, or I should say a new age group or a funded program, it's important to make sure we have good surveillance so we can reassure people, and if there were to be a problem, detect it. So just all be aware that if you go online and you type in WAVS, WAVSS, vaccine surveillance, whatever, you'll go straight to our website where you can report.
The other question I was going to ask you is, based on what's just been asked, you said the Federal Health Minister was going out to sort of publicise this. In view of the fact that the figures that you presented say that the 70 to 79-year-old group's the best, do you know if the Federal Health Minister will therefore be able to head off the grumpy 80-year-old?
I can't give the Federal Health Minister a proposal to my program that was just news to us that they came to the state on a phone call saying, are you going to have vaccine out in your communities by the time he announces this, she announces it? And I said, are they going to announce it starting that day? And they said, no, they're going to announce it starting November 1st. And I said, we're good. They were just checking all the states. So it may evolve. There's even another vaccine in the pipeline that is not a live virus vaccine for Zoster.
Yeah, I didn't mention that, but yeah.
If you want to, you probably know more about it than I do, but it looks like it's highly effective. I think Ian Fraser even had a hand in helping to develop it. So there may be something that this register we use an inactivated vaccine after first round of live virus vaccine, and maybe it would be available for other age groups as well.
If the vaccines are available to order tomorrow, I'll do my order today, so I've got to wait 2 weeks to be able to do my vaccine.
Yeah, so we're going to go through our 2-week cycle because it's very expensive for us to put on separate deliveries, and it'd be hard to say this is an urgent emergency as far as yes.
I've also got an overstock of some flu vaccines left. Can I send them back to you? Do you want me to?
We can sort that out afterward, but normally we just have you destroy it and tell us how many you destroyed so we know. Did I get that right?
I do not have to myself with ZOSTAVAX. From HBA, it ended up costing us $38.
That's quite great.
The other thing was
that would be really reassuring if we were able to get that figure. So we will work on compiling that information.
the other thing was he didn't have much reaction because does a self but a doctor did mine a bit more dermal and had quite a big reaction. just a lot.
Resolved on its own?
Sorry?
It resolved on its own?
Yeah, about 3 weeks though. Quite a bit much reaction there. But quite, you know, just really a little bit shocked.
Hopefully you got a good immune response. Any other clinical questions?
I know you sort of already addressed this in your presentation, but we've got a couple of GPs that for probably over the last 5 years or so have used sort of just the regular varicella vaccination to sort of try and boost immunity and protect some of the oldies against chickenpox.
Yep.
They're going to come in and say, I want the shingles vaccine, but it's currently not recommended. Is that sort of
Look, that is the current recommendation. So just the question is whether if someone's had a varicella vaccine prior in the past, whether they can get the Zoster vaccine. So at the moment the recommendation is not, I think more just because it's unknown about what reactions might occur. I wouldn't particularly suspect that's going to be a major issue, but I guess there's just uncertainty about it. So
I just want to be able to go back and say it's currently not recommended, full stop.
Yeah.
Rather than, allowing the
yeah, so hopefully some more clarity on that sort of front will come out and we can give better advice, but that's currently...
That would be a really atypical situation, though, where a provider was given what's typically a childhood chickenpox vaccine to people that are 70 now.
It's been, I've worked in about 3 different places, and I've come across 1 or 2 providers at every place I've worked at that's done it for that age group. So I suspect it's probably...
They don't have chickenpox parties for all
Yeah, well, it would be.
That's what I hear in that, is there's sort of an off-label approach, and it wouldn't surprise me if they decide to go with Zoster vaccine off-label, because, there's also a cost-benefit situation, and it may not give any additional benefit if they've already had chickenpox vaccines. So you don't really want to fund it as a program. It's harder to know if it really is going to result in more serious complications, because we're all carrying that virus and it reactivates.
Yeah.
And you can give it a year after you have a reactivation, which you would have thought was a huge immune boost.
Yeah, so I suspect it's probably not going to be an issue, but yeah. But yeah.
If you've had the chickenpox vaccine, the varicella vaccine, how long do you have to wait until you can have the ZOSTAVAX?
Well, at the moment you can't have it under the recommendations.
So you could ever in your life have the varicella?
Yeah, but it's only been available for a few years and it's recommended for kids, so there's not going to be too many 70-year-olds who will have had a primary course of varicella.
Yeah,
so there will be some, but most people.
They started with CRC because I was not immune and I had the disease. So
yeah, so there'll be a few rarer.
We're saying people with shingles, and so if they've had an active case of shingles, it should be a year before they have another one. How set is that year recommendation?
Look, that was one. Sorry, so the question was about if someone's had shingles, do they need to wait a year for the Zoster, and how set is that recommendation? I think it's not entirely known. It may be a little bit arbitrary. They're probably going to be fairly well protected from that boosting anyway, and so it's probably not particularly urgent again for that individual, but. I don't think that's an absolute thing either.
Okay, so as long as they have been and are healthy for a long time after they've had their shingles outbreak, it would be acceptable if they're closer into the 12 months term.
Yeah, I mean, they should certainly have recovered from their illness and shouldn't have any lingering effects.
But then the question is, how long do we wait? Like you were saying, it's 4 years. So do I go, okay, the patient's had it this year.
Yep.
Shall we wait 1 to 4 years, or should we just wait a year and do it?
Yep, asking questions. So that's just how long should we wait? I don't think anybody knows for sure. There is a sort of steady decline in that immunity after the vaccination is given, but that will vary between individuals. So there's not any good way we have of knowing a good correlate of immunity. So, yeah, big question mark.
And on a practical thing, I would give it to them when they are eligible and think that within 4 years we'll have a newer, better vaccine or know what we're going to do for second doses already.
Yeah.
So maybe do that.
Give it to them when they're eligible, and with the hopes that we'll have some clarity 3-4 years out to know what we need to do then. Any other clinical questions?
Some people still try and get it to them when they've got it. How some people use restrict.
So, yeah, questions about some people are using the ZOSTAVAX as treatment.
Yeah.
No, I just don't think it's useful in that situation. You're full of kind of immune response at that stage anyway. It's not going to suddenly protect it, you against it. So, you know, an immune response takes time to develop. It's not an immediate thing. It's not like Zoster immunoglobulin, you know, which you might use in someone who's not immune, who gets exposed and they're at high risk, you know, which is trying to mop up free virus and stop infection occurring. You know, this is a different kettle of fish altogether. So.
Does it work at all for the neuropathic pain, or is it more just people had a vaccination for it, therefore I think, cool, it's nothing, okay?
Yeah, maybe a placebo effect. Not everybody gets the complication of post-herpetic neuralgia, so there will be plenty of people who would get it and say, look, it worked for me, but they might have not got it as well.
Okay, just a couple more questions.
Can I ask one question? In practical sense, where our vaccination registers are fairly full anyway, is it going to come in packs of 10 or are they going to come individually?
It's available as 10 packs and singles.
That is a practical question. All right, one more question, unless there's more time. Is that you?
I don't think that's necessarily a contraindication from what I came across. Have to just double check the product information, but yes, I don't think.
I haven't seen it either if it wasn't related to severe immunosuppression.
Yeah, exactly. So, yeah.
Are there any other burning questions? Questions for people on the monitor. Thank you. I guess they're all gone. There's a couple of you who stayed with us. It's hard to do questions over the mic. Email us your questions if you have them, and we'll sort them